Hello friends, welcome to this video on the pathogenesis of carcinoma cervix. When we see the normal structure of the uterus has myometrium and it has an inner layer of the endometrium, and the lower portion of the uterus we call it as the cervix. Cervix has endocervix and ectocervix. Now endocervix is the part which is surrounding this endocervical canal. This is the endocervical canal, and surrounding that we have the endocervix. And ectocervix is the one which is exposed in the portio vaginalis. So at birth, the squamo-columnar junction will be present within the endocervical canal. Now endocervix, this will be lined by a single layer of columnar epithelium, and the ectocervix, it will be lined by the squamous epithelium. So this is a squamo-columnar junction which is present within the endocervical canal. So as she grows at the puberty, what happens is, due to the effect of the hormones or the tissue growth, the squamo-columnar junction, it comes into the ectocervix. Now we have a portion of the cervix which is present in the portio vaginalis, that's also covered by the single layer of the columnar epithelium. So at the puberty, there is a production of the estrogen hormone. So this estrogen hormone, it causes the maturation of the squamous epithelium. Maturation means nothing but the superficial squamous cells, they accumulate the glycogen. So as we know, the stratified squamous epithelium, it has the property that the superficial cells will be desquamating off, and again the basal cells will be proliferating. So once the maturation of the squamous epithelium occurs, the superficial cells which have glycogen in them, they will be shed in the vaginal cavity. So this glycogen which is present in the superficial squamous cells, it becomes a very good substrate for the growth of the bacilli. So the lots of lactobacilli grows there. So when the bacilli grows, the pH falls. So we have an acidic pH falls. But to that acidic pH, the single layer of this columnar epithelium is very sensitive. So slowly this single layer of columnar epithelium will be replaced by the multi-layered squamous epithelium. Now this part which has been converted again to the squamous epithelium, we call it as a transformation zone. Now this transformation zone is very important because this is the area which is prone to develop the malignancies. Now coming to the carcinoma cervix, this is the third most common cancer in women, and 17% of all the cancer deaths occur because of this in between the age of 30 and the 69 years, and this is more common in the Indian women when compared to the women in the developed countries. It is when we see the statistics, it is about 1 in 53 Indian women they develop the cervical carcinoma, when compared to the other developed regions where we have 1 in 100 women getting this cervical carcinomas. Coming to the pathogenesis, what is the cause of this cervical carcinoma? So the most important etiological factor is human papillomavirus. This is a virus which belongs to the Papoviridae family, and this is an icosahedral virus. It has a capsid on the surface. It is a non-enveloped virus. It has a capsid, and in the capsid we have 72 pentameric capsomeres. You are seeing here pentameric capsomeres. Such sort of capsomeres, we have 72 pentameric capsomeres which are embedded in this capsid. And the capsid has two proteins, L1 protein and L2, late 1 and late 2, and within the virus we have a double-stranded DNA which will be wound around the histones. So this is a double-stranded DNA virus which is non-enveloped, and this is how it appears in the electron microscopy. Now, what are the risk factors for the development of the cervical neoplasms? The first is the early age at the first intercourse, multiple sexual partners, increased parity, and the male partners with multiple previous sexual partners, presence of cancers associated with the HPV, and certain HLA viral subtypes, and exposure to the oral contraceptives and nicotine. If we see all these factors, the first factors, they increase the exposure to the human papillomavirus, and some of the factors are which will be affecting the immune response of the patient. So these are the risk factors for the development of the cervical neoplasm. So coming to how the infection of the HPV occurs, during the sexual activity, the HPV exposure occurs to this transformation zone. So we have a squamous epithelium and adjacent we have a squamocolumnar junction. So the HPV exposure occurs to this squamous epithelium as well as endocervical columnar epithelium also. So when the squamous epithelium is affected by this HPV, we have squamous intraepithelial lesion. Now, in the human papilloma virus, we have two types, low risk and high risk human papilloma viruses. So, low risk human papilloma viruses are HPV 6, 11, 42, and 44, whereas high risk viruses are 16, 18, 31, 33, 35, out of which 16 and 18 are very important. So, if the person is infected with a low risk HPV, they rarely develop squamous cell carcinomas. Instead, they will be developing condyloma acuminata, some other lesions, or they may regress also, but rarely they develop the squamous cell carcinoma. Whereas if the person is infected with a high risk HPV, that is 16, 18, 31, 33, and 35, they will develop high grade dysplasias, and if they have the additional risk factors, like if they have the habit of smoking, they are using the oral contraceptive pills, high parity, altered immune status, and some host gene alterations. So if these risk factors are also present, definitely the person will develop squamous cell carcinoma. So if the squamous epithelium is affected by the high risk HPVs like 16, 18, then she will develop the squamous cell carcinoma. If the endocervical columnar epithelium is affected, similarly like the squamous intraepithelial lesion, we have glandular intraepithelial lesion. Now here the most common HPV types are 16 and 18. Now when these 16 and 18 infect the columnar epithelium, it leads to adenocarcinoma. So if the columnar epithelium is infected by the HPV, it causes adenocarcinoma. If the squamous epithelium is infected, it causes the squamous cell carcinoma. Now, one thing we have to remember is the human papilloma virus, it does not infect the superficial squamous epithelium. Okay, so it infects only the immature metaplastic squamous epithelium, or there should be some break in the surface epithelium. There should be damage to the surface epithelium so that it has an access to the immature basal cells which will be proliferating. So either it can infect the basal epithelium or it can infect the immature metaplastic squamous epithelium, but it cannot infect the normal, completely matured superficial squamous epithelium. And though it infects the basal cells, replication occurs in the maturing squamous cells. Now, usually what happens in the squamous epithelium is only the basal keratinocytes will be proliferating. But during the differentiation from the basal cells to intermediate to superficial cells, the cell cycle will be arrested in the G1 phase and the proliferation doesn't occur. But if the cells are infected by the HPV, even the proliferation occurs in the superficial squamous cells also. So along with the proliferation of the squamous cells, even HPV also proliferates. And it uses this host cell DNA synthesis machinery to replicate its own genome. How does it do? We'll see it. So this is how it infects. This is a normal squamous epithelium. We have basal cells, we have intermediate cells, superficial cells, and the HPV, it doesn't infect the superficial cells. There should be some break in the surface epithelium so that it has an access to the basal cells. So once it infects the basal cells, the DNA of this HPV enters into the nucleus and remains as an episomal DNA, like in the circular form. Episomal DNA means it's present in circular form and it doesn't integrate with the chromosome of the cell, DNA of the cell. So it remains as an episomal form. Then slowly it starts proliferating as the cell is proliferating. So when the cell is proliferating, initially it produces the viral proteins it produces, even and E2. During this phase, the proliferation is somewhat lower. But as it is going above, then the proliferation is increased. You have high level of the episomal proliferation or the replication. Along with that, you have increased production of the viral proteins like E1, E2, E4, E5, and E6 and E7. So these proteins are also produced. Then finally, in the superficial cells, it starts producing L1 and L2 proteins. So once these L1 and L2 proteins, if you remember, these are the capsid proteins. So once they are produced, the viral assembly occurs, all the proteins, the assembly occurs, and the virions are released outside. So this is how it infects the basal cells, starts proliferating, and then in the superficial cells, we have the virions which are formed, and then they are released. Now in this one, as I told you, normally as it is going towards the superficial, the cells will not proliferate. But here when it is infected by the HPV, even the superficial cells will be proliferating. And as the cells are proliferating, along with that we have the HPV DNA also proliferating, so that it will be producing its own proteins, and then it will be doing the viral assembly. Now, how does this HPV do? How does HPV cause the proliferation of the squamous cells? Now, this HPV, it has two proteins, viral proteins E6 and E7. These two proteins, they interfere with the activity of the tumor suppressor proteins, and then they regulate the cell growth and survival. Now, how does it do that? As I told you, HPV, it has two proteins, E7 and E6. So HPV E7 protein, it binds to P21 and P27 and inhibits it. These are cyclin kinase dependent inhibitors. Similarly, it also inhibits the RB by causing the degradation, whereas E6 protein, it causes the degradation of P53 and it causes increased expression of the telomerase. Now, inhibition of P21, P27, RB, P53 and increased expression of the telomerase, all these things, they cause increased cell proliferation, immortalization and genomic instability. Now we'll see each one, how does it cause. This is in the normal cell. What happens is RB will be present, RB protein is present as a hypophosphorylated form. Now in the hypophosphorylated form, it forms a complex with the E2F protein. Now this complex of RB with the E2F, when it combines at the E2F site on the DNA, usually they recruit the proteins which are essential for the repair of the DNA. So histone deacetylase and histone methyl transferase, these are the substances which are recruited for the repair of the DNA. At the same time, it also inhibits the transcription of the S-phase genes, which are responsible for the production of the proteins which push the cell into the cell cycle. So the normal function is, when it is in the complex form RB with E2F, it recruits the substances which are required for DNA repair and it blocks the transcription of the S-phase genes. So when the cells are infected by the HPV, now HPV has E7 protein. So this E7 protein, it combines with the RB and it directs it into the proteasome pathway for the degradation. So RB is degraded. So when the degradation of the RB occurs, E2F is left off freely. So this free E2F combines with the E2F site. When E2F is present, simply the only E2F, when it combines to the site, it causes the transcription of S-phase gene, so that the proteins are produced which push the cell into the cell cycle. So we have cell cycle progression, and when only E2F is present, this cannot recruit the substances which are required for the DNA repair. Like we have seen here, if it's present in a complex with the RB, then we have the recruitment of histone deacetylase and histone methyl transferase, which are useful for the DNA repair. So if it is not present in the complex, it cannot substitute or recruit those substances. So you have a defect in the DNA repair. So you have a cell cycle progression, and also you have an impaired ability of the repair of the DNA. Similarly, as I told you, it also combines with the P21 and P27. These are cyclin dependent kinase inhibitors. So if these are normally functioning, they keep the RB in the hypophosphorylated state. But when these two substances are inhibited, then the RB is hyperphosphorylated. Once it is hyperphosphorylated, it releases the E2F from the complex. So this E2F, when it is released, it combines with the E2F site and causes the same thing. It causes the transcription of the S-phase genes, which are responsible for the production of the proteins which pushes the cell into the cell cycle, so cells start proliferating. This is how E7 protein functions. When we see the E6 protein, it combines with the P53. If you remember P53, usually whenever there is a DNA damage or nuclear material damage during the cell division, the cell cycle stops there and it gives some time for the nuclear material to repair itself. If it cannot do that, then P53 activates and it pushes the cell into the apoptosis, so that the cell with the abnormal DNA doesn't enter into the cell cycle. So activation of P53, it inhibits the cell survival by apoptosis. So E6, it combines with the P53 and it causes the degradation of this by the proteasome pathway. So once P53 is degraded, the cells doesn't undergo apoptosis, but the cells survive with the abnormal DNA and they start proliferating with that abnormal DNA material only. And similarly, this E6, it also causes the increased expression of the telomerase catalytic subunit. If you remember, the telomere is present at the tip of the chromosomes. So these telomeres, whenever the chromosomes are dividing, for every division, a part of the telomere is lost. So until it reaches a very small size, the telomere, when it becomes a very small, then the cell cycle will stop. But what happens when there is a telomerase enzyme? It will be recruiting the telomere which is lost again. So the length of the telomere is retained. So the cell will be dividing infinitely. It doesn't stop. So E6, what does it do is it causes the increased expression of this telomerase so that there is an immortalization of the cell. So E6 combines with P53, degrades it, and it causes the increased expression of the telomerase. Now this virus will be present in the different states in different lesions. So if, as I told you, it will first infect the basal epithelial cells. If the infection is by the low risk HPV, it will be present as an episomal form. Episomal form means extra chromosomal form, which is present in the circular form. It doesn't integrate with the host DNA. So if the virus is present in this episomal form, it leads to certain conditions like condyloma acuminata, and slowly it may regress also. Whereas if the infection is by the high risk HPVs like 16, 18, 31, 33 or 35, the viral DNA, it integrates with the host cell DNA. Now once it integrates with the host cell DNA, that leads to the malignancy. So in the malignant conditions, the DNA is integrated, viral DNA is integrated with host cell DNA, whereas in the benign conditions like condyloma acuminata, it is present in the extra chromosomal episomal form, circular form, which is not integrated with the host cell DNA. Now, when you see this normal squamous epithelium, once it gets infection with the HPV, it takes about 1 year to develop the low-grade squamous intraepithelial lesion. Now, this low-grade squamous intraepithelial lesion, this virus can be cleared by our immune system only. The T cells can clear them. So 60% of the clearance of the HPV occurs. 60% of the cases they can clear off the HPV. And by 3 years, 90% of the HPV is cleared. But the remaining 30% of the cases, it just persists within the cell. And it takes about 1 to 5 years for the development of the H cell from the L cell. H cell means high-grade squamous intraepithelial lesion. So 10% of the cases only from the L cell they progress to H cell. Whereas once the patient develops H cell, 30% of the cases they can regress back to L cell. And from the H cell, 10% of them they go to the squamous cell carcinoma. Here also 60% of the cases they just persist with the H cell only. So once the patient develops L cell, 30% of the cases can persist with L cell, or 10% may progress to H cell. And once the patient develops H cell, 60% of the cases may just persist with the H cell, or 30% can again go back to L cell, and 10% can develop the squamous cell carcinoma. But for the entire process, for the development of the squamous cell carcinoma from the infection, it may take about 15 to 20 years. The long time it takes for the development. So during this long period, if we are able to detect the cells having the L cell changes or the H cell changes, we can give the treatment so that the patient will not go into the carcinomas. So because of this long latency period, Papinocole smear screening technique has become very famous because by this screening we can detect the cells with the L cell and the H cell changes, and we can give the treatment before only. So how we have given this changes as an L cell and H cell or CIN1 2, we'll see. So depending upon the presence of the atypical cells in the different layers of the squamous epithelium, they have classified them as cervical intraepithelial neoplasia 1, 2 and 3. Now first, initially when they were describing, they described it as mild, moderate and severe dysplasias. Later on, the terminology was changed as cervical intraepithelial neoplasia 1, 2 and 3. And as I told you, this division is based upon the presence of atypical cells in different layers of the squamous epithelium. Like CIN1 was given if you have the presence of atypical cells in 1/3 of the thickness of the epithelium, and CIN2 is given if we have involvement of 1/3 to 2/3 thickness of the epithelium by the atypical cells, and CIN3 is if we have involvement of the full thickness of the epithelium by the atypical. Now here you see, now previously this was called as CIN 1, 2 and 3. Now the WHO has given a new reporting system, what we call it as a Bethesda system. In that we report it as low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion. So the cases which were described as mild dysplasia was later described as CIN1, and now it has been described as low-grade squamous intraepithelial lesion. Whereas moderate dysplasia was given as CIN2, and this comes under high-grade squamous intraepithelial lesion. Even the severe dysplasia, which is called as CIN3, it comes under high-grade squamous intraepithelial lesion. Carcinoma in situ, it comes as CIN3, and here it comes as high-grade squamous intraepithelial lesion. So totally now in the newer system, the current classification or reporting system of the Bethesda, they have divided as just L cell, H cell and invasive carcinomas. Schematic representation. This is the normal squamous epithelium. This is how you see the cells in the pap smear. So these have a small pycnotic nucleus. So in the mild dysplasia, you have 1/3 basal 1/3 of the cells showing dysplastic change. Atypical cells are there with increased nuclear cytoplasmic ratio. And this is how you see in the pap smear. So you have a slight increase in the nuclear cytoplasmic ratio. Then this is a moderate dysplasia where you have involvement of 1/3 to 2/3 of the epithelium. You have atypical cells in 1/3 to 2/3 of the epithelium. You see still more increase in nuclear cytoplasmic ratio, a large nucleus you have. This is CIN2 or the H cell. Then in the severe dysplasia, if you see, entire epithelium is showing atypical cells. And you have in the pap smear, you have the cells having a large hyperchromatic cells with large hyperchromatic nuclei and scant cytoplasm. So even CIN3 comes under H cell. And in the invasive carcinoma, you see that the cells are invading into the stroma from the basement membrane. They are not confined above the basement membrane, but they are infiltrating from the basement membrane into the stroma. And the cells will be similar as we see in the CIN3. But here in the carcinoma, we see actually the sheets of pleomorphic cells, which are having hyperchromatic nuclei with the scant cytoplasm. So this is how the cells appear in the biopsy, depending upon the thickness of the squamous epithelium involved, and this is how the cells appear in the pap smears. Papinicole's cervical screening. In that smears, the cells appear like this. This is the micro photograph. You can see this is the normal squamous epithelium where you see just the pycnotic nucleus, and here you have the involvement hyperchromatic nuclei you are seeing till here. This is CIN1. If you see here till here, you are seeing the loss of the polarity and the large nucleus. This is CIN2. But if you see here in the CIN3, the entire thickness is showing the cells with the hyperchromatic nuclei and with the scant cytoplasm. This is CIN3, cervical intraepithelial neoplasia 3. So this is about the pathogenesis of cervical carcinoma. I request you to please give your comments on my video so that this will help me in improving my classes. Thank you for listening patiently.